I began to worry about overtreatment in this country in something of a flash. It was looking at two graphs, very simple graphs. One was the increase in life expectancy over time over the 20th century, and the other one was the increase in per capita spending in the last half of the 20th century. And one of them was going up very, very steeply, and the other one was not budging.
Not surprisingly, countries that don't spend very much don't live as long, and if you spend more money, people tend to live longer. So at the one end, you've got countries down here where they spend about $1,000 or so per person, and they live about 74 years. And you've got countries up here, Norway and Japan, places like that, where they spend a lot more money, $4,000 plus per person, but people live longer. They live about 82 years, and you can see a general trend here that bounds all of the countries in the OECD. Now there's an exception, and you probably noticed it, this lonely little red dot over here to the right. That is the United States. Proud yet? Boy, I mean, it's very disturbing to see that. United States, we spend about twice as much as the typical country in the OECD, but we're getting average or actually slightly below average life expectancy. You know, we should be up here somewhere. We should be living 86, 88, 90 years. It would be a real stretch to say that based on how much we're spending and how little value we're getting for that we somehow have the best healthcare system in the world.
So many patients are going through screenings and treatments that are harming their health, and a lot of times they don't even know it. And I wanted to investigate this further and see how widespread it was. I found out that there are a lot of screening tests that are unnecessary. There are a lot of treatments. And patients think, well, it's a blood test. Why don't I find out? At least I'll know. What they don't know is that automatically leads to all this downstream cascade of intervention.
In the United States, the framework for thinking about healthcare has been one of shortage. When you have 40 million people who are uninsured, the way you think about healthcare is, I'm not getting enough of it. So I think patients, for the most part, are still locked in this mindset that they're simply not getting the care that they need. And it's true, many people do not get the care that they need in this country. But people are becoming aware of the fact that there's also such a thing as too much care. And I know this because I wrote a book 5 years ago called Overtreated, and when I first came out with the book, people looked at me like I was crazy. This is not exclusively an American problem. We know that overuse is a problem throughout the developed world. We know it from a number of sources of evidence, but one of them is the fact that there's variation in rates of elective procedures, even within a country the size of Great Britain.
I wanted to understand how this problem of undertreatment meshed with the problem of overtreatment. And it turns out that they are really twin sides of the same coin. I wanted to interview David Himmelstein because he presented a pretty unique perspective.
We have a unified problem of a healthcare system that doesn't work, and it doesn't work for people who can't get access to care, and it doesn't work for people who have care that they not only don't need, but that's abusive of them. As a resident, I was at a public hospital in Oakland, California, where we had an utter lack of resources to care for our patients, and then rotated through a private hospital nearby for our cardiology training. And I saw that not only were patients not being denied care, but they had this enormous ICU where people were very commonly getting procedures that did them no good and may well have done them harm. So in one community, I came to realize we had the resources to actually have a good healthcare system for everyone, but they were divided between, on the one hand, people who were denied care, and on the others, people who were profitable for the system to provide excessive amounts of care.
When we adjust for differences among populations, what we see is tremendous differences in how similar populations of patients are treated. And this runs completely counter to what patients think about how medicine works, and it also runs counter to how physicians think they behave. They think they are treating the patient in front of them on the basis of evidence and a basis of their experience, their discretion. When in fact, a lot of how they end up treating patients has to do with the culture around them, the particular culture in the particular hospital. The fee-for-service payment model that dominates how most physicians are paid in this country and how hospitals are paid, really, incentivizes everybody to deliver more care. You get paid more to do more. You don't get paid more to do better.
Every study shows that if you incentivize doctors to do more, they will do more. Not everyone, every time, but overall there is a shift to doing more. Similarly, if you incentivize doctors to do less, they will do less.
Just thinking of a personal family situation, my youngest daughter had a torn anterior cruciate ligament, and the surgeon who operated on her made $4,000 for the hour and 15 minutes in the operating room. I think he made something like $50 for sitting and talking to us about the options for surgery. So there's an enormous imbalance there.
I remember vividly a case of a patient who came for a second opinion, had been told, a 90-year-old who was told they needed to have a particular surgical procedure, had a lot of other morbidities and problems, which on balance made the surgery extremely high risk. And the question was, would you exchange the life you had now, which would slowly dwindle, undoubtedly, for a shot at an extra, some unspecified period of time? And we recommended that the person defer surgery, given everything about the patient, their life. Others had given the initial recommendation, and the various pressures that were brought to bear were such that, you know, this person went ahead with the surgery and ended up having a devastating stroke and ended up dying within a month and a half. And, you know, this happens all the time, and it's not as if the caring physicians intended this, because of course they didn't. They're very caring. The fact is we sometimes don't look at the whole picture, and that's the core issue here.
Anybody who works in an American hospital cannot fail to notice that there is an enormous amount of care that's delivered that patients either don't need or wouldn't want if they understood. This is particularly true at the end of life. So there are many American physicians who are aware of this problem, and I suspect there are probably many European physicians as well.
We know that a huge number of stents placed for coronary artery disease are in people with stable coronary disease, where stents do no good. And yet there's a picture that shows a narrowing, and that picture suggests to the patient that something should be done, and the specialist is happy to exploit it.
We do a lot of stents and a lot of angioplasty, about 1 million a year for our elective procedures. And it's very clear that a very high number of those are not necessary.
I saw a patient who had diabetes, and his diabetes was completely out of control and threatening to kill him. The healthcare provider walked in the room a little disturbed. Why wasn't this patient compliant? Why wasn't he taking care of himself? He was a big man. He was a truck driver. And I'll never forget, he had these big hands, and he just covered his face with his hands and started crying and said, I don't have the money. One of my 5 pills costs $300 a month. So we have that problem at the same time that I see and hear about people like the young man who was found to have a little colloid cyst in his brain on an MRI that was done because he had seizures. And a neurosurgeon rushed in and said that he had to do emergency surgery for this non-obstructing colloid cyst.
The doctor's telling me, my child's gonna die. We're talking 48 hours, 72 hours. He's actually just scaring the death out of us. In the beginning, he never really told us anything that could possibly happen to Michael that was negative because of what he would do physically to him.
There was a fax from our primary care physician that said, do not do anything.
Revisit in 8 months.
Revisit this in 8 months. I want you to just get an EEG. If it is a colloid cyst, it's not doing anything. And when I saw him, I said, this is what our doctor said.
But the neurosurgeon specialist rushed Michael to surgery. Specialists often seem to devalue the expertise of primary care physicians.
primary care has been disempowered in the healthcare system. It's of lower status. Patients generally view the specialist as the carrying much more gravitas, and the message is conveyed in every way in our system.
This previously healthy 22-year-old young man came out paralyzed, unable to speak, unable to walk, had multiple complications, died a horrible death after 32 months of illness and being bedridden, and his costs were estimated to run up to $5 million.
There are systems that are doing a better job. I mean, Denmark, for example, has been reducing the number of hospital beds that it has by providing better primary care, better ambulatory services. And when they find that their beds are not being used as much, they get rid of them. We never do that because hospitals don't want to get rid of beds because you make money on beds.
So what do we need to do?
Well, we need to take some of the terrible incentives out of our system, not pay doctors to do more, and I'm also concerned that we not pay doctors to do less, because we have ample evidence that if you pay doctors to give less care, they will deny care that's needed by patients. There's no good way to pay doctors, but we need to make it as neutral as possible.
And by neutral, you mean salary doctors?
Probably salary is the best way to go, and without incentives to either do more or less. We need to make sure that every patient brings the doctor the same financial reward, so that we don't have some patients who are lucrative and some who are money losers.
How willing are doctors to accept that, do you think?
Oh, I think most doctors would be very happy for that. Surveys show that something like 60% of my colleagues want national health insurance at this point in the United States. But frankly, we also need to recognize that more of the research needs to be public and not a commercial-driven research. So our drug company pipelines are, at this point, quite barren. We've pursued a research agenda which is largely driven by commercial interests, and that both distorts research, and we have increasing evidence that it's not giving good results in terms of innovation.
We don't have the data we need to know what works and what doesn't work and for which patients it works. And part of the reason we don't have the data that we need is we've effectively handed the clinical research agenda to the pharmaceutical and device industries. 80% of clinical research in this country is paid for by industry. So that means that industry gets to choose what gets researched, and industry is only interested in research that involves its products. So we have a lot of drug data. A lot of it not very good, but we have a lot of drug data. We don't have surgical evidence. I mean, most surgical procedures have not been subjected to a randomized controlled trial.
A core issue in the research agenda is that much of the research establishment is riddled with conflicts of interest. The public needs to know what things don't work, what devices don't work. Who is going to fund that? Only the public has an interest in funding those kinds of studies. The lack of an interest in the kinds of care and the kinds of treatments that would reduce unnecessary care is a serious problem.
As a primary care doctor, I have research on any one of 30 or 40 different medications to guide my practice in prescribing. But there's incredibly little research about diet and exercise and as an alternative, and still relatively little comparative research to know which approach is the best in many situations. Each drug company wants to compare its drug to placebos, and that's not relevant in most clinical situations. What we want to know is drug A better than drug B?
I think the journals have a crucial role to play. The journals, I think, are getting better in terms of worrying about conflict of interest. They're certainly getting better on that front. They need to really weed out bad studies. They could also do an enormous service, I believe, if they would do what, for example, the Archives of Internal Medicine has done, which is to set aside a portion of the journal for a section called Less is More. And it's really actively soliciting papers on overuse. If every journal, if every medical journal did this, if every one of the specialty journals did this, it would be tremendous.
I don't want a doctor to treat me who I know is going to get more money if they do more. And I don't want a doctor who's going to get more money if they do less. I want a doctor who will just do the right thing, and it won't make any difference to their wallet.
The outcome would have been so much different to learn that there was another procedure that could have been done that was less invasive, that Michael would still be here.
If nothing changes at the fiscal level, we are on an unsustainable course. But at a moral level, the clinical community will have lost its essence. If we can't control this problem, and the problem consumes more and more resources and harms people unnecessarily, we won't have the resources to take care of all the people who need it. Nor will we have the authority to stand up and be trusted and credible when issues like this come up. And they will come up again and again and again, because technology is going to move forward, and we need to understand how to use technology properly. We can't do it indiscriminately. So if we don't do this, then technology is going to dominate human beings. That's not a world any of us should want.